Okay, so let me just dive right in because the stakes here really couldn't be higher. We're talking about brain tumor surgery, specifically for gliomas. And the surgeon's goal is always, always to get the whole tumor out. But the real problem isn't the big, obvious mass. It's the microscopic, totally invisible tumor cells that creep into the healthy brain tissue around it.
It's a problem it's been around for a century. And if you leave any of that residual tumor behind, which shockingly happens in most patients, you get early recurrence and patient survival just plummets.
It's the ultimate surgical dilemma, right? How aggressive can you be without damaging healthy brain function?
Exactly. And the cost of getting it wrong is, well, it's staggering. We're talking over $1 billion a year in the US alone for follow-up procedures, all because of this tiny invisible line.
So what if AI could draw that line for the surgeon, but in real time, right there in the operating room?
That's the idea.
Today, we are doing a deep dive into FastGlioma. It's an open-source visual foundation model designed to do exactly that, give surgeons fast, label-free detection of glioma infiltration right at the bedside.
And when we say fast, we mean it. We're talking sub-10 seconds. Our mission today is to really unpack how FastGlioma pulls off this incredible mix of speed and accuracy. We'll look at the imaging it uses. It's called stimulated Raman histology, or SRH, then the AI itself, and finally the prospective clinical results, which are pretty stunning.
Okay, so before we get to the solution, let's nail down the problem. Why has this been so hard for so long? Can't they just, look at a slice of tissue under a microscope in the OR?
They can, but the standard method is just painfully slow. It's called H&E staining.
Yeah.
You have to remove the tissue, freeze it, slice it, stain it, and then you wait for a pathologist to look at it.
And there are fewer and fewer pathologists to go around.
Exactly. The whole thing just eats up valuable time.
And what about the more high-tech tools? I'm thinking of things like fluorescence dyes or intraoperative MRI.
They have limitations too. MRI is great, but the brain can actually shift once the skull is open, throwing off a map. And fluorescence dyes, like 5-ALA, they're not always specific. They can light up for inflammation or swelling just as easily as they light up for a tumor. They just lack that microscopic precision at the margin.
Okay, so FastGlioma is built to get around all of that by pairing AI with a technology called stimulated Raman histology, SRH. This sounds less like biology and more like pure physics. How does it work?
It really is molecular insight. SRH is a rapid, label-free imaging method. And the core idea, the real innovation, is that the image contrast comes from the tissue's own intrinsic biochemical properties.
So no stains, no dyes?
None. It reads the tissue's natural chemical fingerprint and turns that into a high-res image.
So it's not looking at the shape of the cells, it's looking at what the cells are made of chemically.
Precisely. It measures the unique vibrations of different chemical bonds. They focus on two key channels. Think of it like two different colored filters. The first one at 2,845 inverse centimeters that reveals lipids.
The fatty stuff. Myelinated axons, the brain's white matter.
You got it, the insulation on the wires.
Yeah.
Then the second filter at 2,930 inverse centimeters highlights protein and nucleic acid-rich regions. That's where you find cell nuclei. And cancer cells, they're known for having a high nucleus to cytoplasm ratio. So more protein, more nucleic acid.
So by mapping lipids versus proteins, the AI gets this incredibly detailed chemical map.
A map that's a much more reliable indicator of cancer.
And this all needs to happen basically instantly. You mentioned there's a speed trade-off.
Right. Full resolution SRH takes about 100 seconds. Better than H&E, but still too slow for real-time use. So they developed a fast mode under 10 seconds.
A 10-fold speed increase.
A 10-fold speed increase.
Okay, wait a minute. If you're speeding it up that much, doesn't that mean lower resolution? Isn't that trading safety for speed? That sounds risky when you're talking about brain cancer.
That is the absolute central question. And it's the problem the AI was built to solve. If you scan faster, you get less data, you worry you'll miss the subtle cues. The entire foundation model was designed specifically to compensate for that loss in resolution.
Okay, let's do a quick recap here. First, leaving even a little bit of tumor behind is the single biggest challenge in glioma surgery. Second, FastGlioma tackles this with SRH, an imaging tech that reads the tissue's chemical makeup, lipids, and proteins in under 10 seconds. So the big question for you is, how did they hit the accelerator so hard on the imaging without sacrificing the accuracy that surgeons and patients depend on?
They did it with a two-stage visual foundation model. And he was trained using self-supervision.
Foundation model. I hear that for things like GPT-4 or DALL-E. What does that term mean for medical images?
It means an AI trained on a massive, really diverse data set. It learns the fundamental visual patterns of the data, so it can be adapted to lots of different tasks later. FastGlioma was pre-trained on about 4 million images from over 3,000 patients across 13 different medical centers.
4 million. You can't have pathologists label all of that. So how does it teach itself? What's self-supervision here?
It's a two-stage process that learns context. Stage 1 is the patch tokenizer. These whole slide images are huge, massive files. So first, it breaks them into smaller, manageable patches, little squares. And this uses a method called HiDisk.
HiDisk, hierarchical discriminative learning. The hierarchical part sounds important.
It is. It leverages the data's built-in structure. You have a patch, which comes from a slide, which comes from a patient. It learns that patches from the same patient are related, even if they look different. It's like learning the faces of a family. They're related even if they don't look identical. So it learns the inherent geography of the tissue without any human ever saying, this part is cancer.
It learns the language of tissue, and then stage 2 has to scale that up from the small patch to the whole slide.
That's the whole slide encoder. It uses a vision transformer, and to really make the learning stick, it uses a Siamese architecture.
Siamese, like the twins. 2 views of the same thing.
Exactly. It creates 2 slightly different views of the same slide. Maybe one's cropped, one has pieces missing, and it has to learn that these 2 distorted views are still the same thing.
And this is where the VIGREG objective comes in. That sounds complicated.
It is, a bit. VIGREG stands for variance invariance, covariance regularization. But think of it this way. It forces the model to ignore the minor distortions, that's the invariance, and it makes sure the model uses all of its feature detecting tools, not just one easy one. That prevents what's called dimensional collapse.
Which is basically the AI getting lazy and cheating.
It's a fancy way of saying it stops the AI from cheating. It forces it to build a really rich, robust understanding of the tissue. And that's how the fast 10-second mode could achieve 88% accuracy, which is almost identical to the slow 100-second mode's 90.2%.
An incredible compensation. So that's how they bridged the speed-accuracy gap.
That 2-stage pre-training was absolutely key.
Okay, let's connect the dots again. We have a 2-stage foundation model trained on millions of images. Stage 1, HiDisk, learns patch structure. Stage 2, VI-Sereg, understands the whole slide context, which makes the 10-second imaging viable.
Correct.
But all it knows so far is what tissue looks like. It doesn't know the life or death difference between a healthy cell and a cancer cell. How did they teach it that critical distinction, especially when medical labels can be so vague?
That's the fine-tuning. And the data set for this was much smaller, only 161 specimens. So to make the most of it, they used a very clever strategy called ordinal metric learning.
Ordinal as in rank or order. What was the ranking system the experts gave it?
The neuropathologist created a 4-tier scale. This was the ground truth. Score 0 was normal brain, no tumor. Score 1 was ambiguous, maybe some atypical cells. Score 2 was sparse tumor, and score 3 was dense tumor infiltration.
And those scores apply to the whole slide, which is what you mean by weak supervision, right? It's general guidance.
Exactly. And ordinometric learning takes those ranks and turns them into a precise, continuous score. It works by maximizing the latent distance between images with different scores.
Latent distance. What does that mean in practice?
It just means it forces the model to rank images relative to each other. So in a batch of images, if one is a score 3 and another is a score 0, the model gets heavily penalized if it doesn't score the 3 much, much higher than the 0. It literally pushes their mathematical representations further apart.
So it's not just classifying, it's quantifying. It creates a continuous score from 0 to 1 that a surgeon can actually use.
That's the goal, a single actionable number. And crucially, they also made it interpretable. They call it few-shot visualizations.
Meaning the surgeon can actually see why the AI made its call.
Yes. A surgeon can select a region, and the system compares it to a small set of reference images, say 10 examples of normal and 10 examples of tumor that a doctor chose. It then generates a heat map showing the most suspicious areas. And the best part is, you can change those reference images on the fly without retraining the whole model.
So it's explainable and adaptable. Okay, now for the real test, the prospective validation. They put it head-to-head with the old methods in a real clinical trial.
And this is where the results get really exciting. It was a multi-center international trial, 220 patients. The overall performance was excellent. An A-ROC, which is a measure of accuracy, of 92.1%.
Very accurate. But what about different types of tumors. Could it generalize?
It did. Performance was high across all the major glioma subtypes.
Yeah.
But even more impressive, it showed zero-shot generalization.
Zero shot. So worked on tumors it had never, ever been trained on.
Absolutely. Without any specific fine-tuning, it accurately detected other kinds of brain tumors, metastases, lymphomas, meningiomas. It proved the foundation model really learned what cancer looks like, not just one specific type.
All right, this is the main event, the head-to-head comparison, the AI versus standard of care. And they focused on the most critical decision. Score 0, which means stop cutting, versus score 3, dense tumor, keep cutting.
They compared FastGlioma against 5 ALA fluorescents and 2 different MRI markers. The results were, well, they were decisive.
Give us the numbers.
FastGlioma achieved an AROC of 98.1%. 5 ALA fluorescents came in at 89%. Flare-up positivity from the MRI was 76.3%, and contract enhancement was even lower at 71.8%.
It's not even close. It just crushes them.
It's because FastGliomas are giving a direct microscopic chemical reading. The others are all indirect, ambiguous indicators.
And you mentioned that flare positivity from an MRI can be confusing. It could be swelling or it could be tumor. Did the AI solve that?
Critically, yes. FastGlioma could correctly tell the difference between real tumor infiltration and just non-specific brain swelling, even in those areas that look confusing on an MRI.
Which brings us to the bottom line, risk reduction for the patient.
In the control arm, using standard methods, patients had a 24% risk of a high-risk tumor miss, meaning dense, resectable tumor was left behind. In the FastGlioma arm, that risk was only 3.8%.
Wow. Let me just repeat that. A 24% risk drops to 3.8%. That's a 6.3 times relative risk reduction. It's giving surgeons the microscopic clarity in seconds that they've needed for 100 years.
It's really a powerful demonstration of what these medical foundation models can do. It's rapid, it's label-free, it's microscopic, and it's quantified. It overcomes all the old limitations at once.
This feels like a huge step forward for glioma surgery globally.
And the research suggests this same workflow could be applied to so many other cancers.
Yeah.
Lung, breast, prostate, anywhere surgical margins are a problem.
Okay, so let's leave our listeners with a final thought to chew on. This combination of AI and new optics like SRH is turning the literal chemical signature of a cell into digital, actionable data in just a few seconds. If we can now essentially eliminate the problem of dense residual tumor in one of the most difficult surgeries there is, how far are we from a future where all cancer surgery margins are verified instantly worldwide? And what other bottlenecks in medicine, one that's plagued by slow, ambiguous diagnostics, do you think is ripe for a foundation model intervention next?